Hello and welcome to the Unit 3 presentation on documentation for fundamentals. Remember, this is one of two presentations, so make sure you see the presentation on communication as well. All right, these are some of your learning objectives for the unit. The rest of them are listed in the communication presentation, and the complete list is in E360 and also in your learning plan packet that I handed out. So why do we keep a medical record? Well, simple. To prove that cares and treatments were performed and to provide a source of communication for the medical team. There's many other reasons, and these are all listed on this slide, but the big ones is the legality of it and the communication piece of it. Resources for care guide many aspects of what is included in the medical record or the EMR. For example, some EMRs send alerts to providers if the patient needs something evidence-based, such as a vaccine that they're due for, or if a prescription is not advised that a doctor orders based on what new research says. So this will send out flags, and then the patient can get the most up-to-date care. EMRs provide a way for patient records to cross specialties and sometimes even organizations. So this intent was first mandated with HIPAA that we talked about in week 1. The privacy laws, were designed for patient privacy, but they also were designed for portability of healthcare records. And they outlined a need for comprehensive databases that the patient could take with them. In reality, though, what happens is the data can only be transmitted across organizations if they use the same EMR software, and there are a lot of different EMR softwares out there. But generally speaking, EMRs allow for safer patient care through the use of things like barcode technology, computerized physician order entry, and drug interaction flags, among other things. So overall, they're a good thing. It's just unfortunate that there's so many different ones, so the process of transmitting isn't as streamlined as what people had hoped for. So if we're going to document, there are a lot of do's and don'ts. So with confidentiality, we only discuss patient information with those professionals directly involved in patient care. We don't talk about it with family or friends without the permission of the patient. We don't discuss the patients, even if you're not using their names in public places, because some of these more obscure things can be really patient identifiers in and of themselves. We don't leave our computer with patient info unattended because people can get in there and then they're searching around in your name. Don't remove the chart from the patient care area unless you're accompanying the patient to a procedure, and then it would be expected you take the chart with. Students should write information for assignments without patient names because we don't want anything to accidentally get left out and have an actual patient name on there. For accuracy, we want to only chart observations that you have seen, heard, smelled, or felt. Use precise measurements and times when possible. Use correct spelling in medical terms. And if you make a mistake, that's okay. But if you're doing paper charting, you can't use whiteout, you can't erase it, you can't scribble it out. The right way to do it is you just draw one line through the error, and then you write charted in error with your initials by it. Documentation should be complete, and this includes assessments, nursing interventions, medications that you gave or held, provider's orders that you carried out, provider notification of a change in patient status, patient teaching, patient responses, and any change in the plan of care. Should be concise. We want to use partial sentences. Drop the patient's name when you're charting in the patient's chart. Only use approved abbreviations, because sometimes what you think is an abbreviation for something, someone else has a totally different idea of what that might mean. We want to keep them objective and factual. And remember, this is a legal document, so if we keep our charting objective and factual, this protects you from litigation, but it protects the patient also because they're going to have an accurate objective report and hopefully not a bunch of our biases poured out in their charting. Directly quote statements made by the patient in quotes. So we want to say, for example, the patient states they're missing the company of friends and is upset they're no longer visiting. That sounds pretty objective. If we put the patient's lonely and frustrated, that is not objective. That is our interpretation of the patient's actual behaviors, and that would be not appropriate. We want to organize chronologically, so we want to start at the beginning of the shift and head towards the end of the shift. Timely. Point of care documentation is best. So this means charting as you're doing something. So if you're giving a medication, you should be charting it then and there. If you're putting in a catheter, you should be charting it then and there. If you can't do it right away, like with your assessments or treatments, do it as soon as possible and make sure that your time that is put on the charting is actually the time you did the procedure or you did the assessment and not the time you're actually charting, if there's a discrepancy there. You want to use 24-hour military time, and also avoid batch charting, which is where you save all of your charting on all of your patients and you just chart that all at the end of your shift. And the reason you don't want to do this is because we get busy and sometimes we forget and we might omit important information or data or record something inaccurately. And then, of course, if you're using a paper system, you want to write legibly so that other people can read what you wrote. So charting by exception is documentation that uses flow sheets to make charting more efficient. So typically what happens is you check off anything that's normal or within defined limits, and then if there's something abnormal, you would like put a star or somehow mark it, and then you would expand that assessment and chart more on that in more detail. And also there's 3 types of nursing notes that go along with your documentation. The first one is narrative notes, and this isn't any particular format, but narrative notes just tell a story. So if you were just charting how your patient did throughout the shift, there's not necessarily a problem, but just kind of like a status update. So you would just chart that in a narrative note. A SOAP note, this is a note that is more focused on one issue that the patient might have. So S is subjective, and this is data or symptoms that the patient expresses. O is objective, and this is data collected by the nurse that's applicable to the problem, such as what the nurse can see, hear, smell, whatever. Lab data, diagnostic tests, and vital signs. The A is assessment. So this is our impression or condition change or diagnosis that we have, and it's made after analyzing subjective and objective data. And then the P is the plan. So this is the nursing interventions that are specifically related to the identified problem. So it could be something as simple as continue to monitor. I will continue to monitor this. It doesn't necessarily have to be a resolution, but just that we're watching it. So a DAR note also should be written for each abnormal problem noted on the flow sheet. And this is a little bit different. This is asking for your data, so that's your objective and subjective data for a particular problem. So if they have 5 problems, they need 5 DAR notes. Okay. Your A is your action, so that's what was done about the problem. And then R is response by the patient to what you did about the problem. Did the problem get better? Did it not get better? What further follow-up do you need to do? And this here is just an example of a charting by exception flow sheet. So you can kind of look through how they just X the normal ones and they kind of circled the abnormal ones and made a little comment to look at the notes for more information. This one's a DAR note example. You can read through that. The one thing that I don't like about this DAR note is if you notice partway down, they leave a lot of lines blank. And you really should draw the line out to the end. You shouldn't leave any blank spaces because then somebody could come along and falsify your documentation. All right, so one of the sections in E360, you'll find a copy of various forms used at a skilled nursing facility. And this information is given to you now, just not that you'll be tested on it, but it's to prepare you for your clinical rotations that you'll have this semester at nursing homes. So we routinely document, but also the nurses will go through and audit the documentation. And this is done for reimbursement and quality assurance purposes. So it is important to be familiar with those forms. All right, and now the incident report. So this is the last part here. And the incident reports are separate reports used to document an occurrence. So what's an occurrence? Anytime something doesn't go how it was supposed to. So your patient fell, you gave them the wrong medication, something like that. We fill out the report not to punish, but so we can look at it, we can follow trends in incidents that might happen, and we can learn from them, and we can hopefully get some quality improvement from them. The specifics of the incident, like in quotation, the patient attempted to get up alone and fell, landing on his left hip, along with any interventions you did to help the patient or any outcomes of the incident, these all get documented in the patient record as a note. However, you never put in the chart, I filled out an incident report. That's never mentioned or entered, because as soon as you do that, if the Joint Commission or a lawyer or anybody is looking through that chart and they see that, you know, I filled out an incident report in the chart, then that gives them access to that incident report, and we have to, the organization has to show them that. And it's really meant to be an organizational tool and not a part of the patient care record. So pause here and just think for a few minutes, how would you chart if you gave the wrong medication to a patient? And I'd like you, if you would, just to write out a brief narrative note chart entry to describe that incident, just to get practice with it. So to recap, you want to make sure you can answer all the bullets on this slide. And if you have questions with any of them, I would recommend going back and reviewing, or you can email me a question. Thanks, and have a great day.